So here in this segment, we're going to look at some studies that where we can use all Medicare data, Part A and Part B and Part D data, right? So well, we have covered that studies that use only Part D PD data or studies that use only plan or formulary files. And now you probably want to link, okay, let's combine with the Part A and B data and let's do some research. But before that, let's think about some research that what kind of research you could do using all this A and B and D data. So these are just the examples. You might have a little bit more and better ideas. And just for examples, you could do some outcomes research. So you can say some drug users and non-users and see whether there are differences in health outcomes. Right, Sovaldi users versus non-Sovaldi users. Those who didn't use Sovaldi, is there any difference in survival? Which actually we did, and which we published on the survival effect of Sovaldi. And then also some might be interested in comparative effectiveness research. And this case is where you want to compare outcomes between these two drugs. Well, okay, is there any difference between Sovaldi and Harvoni? And what's the difference? And what about Viekira? Why some plans don't cover Viekira? Do they have some leads to some different health outcomes? That's another example. And then another one is looking at some cost offsetting, right? So we covered yesterday the statins. Our assumption was that if you have a better statin adherence, you may actually reduce some hospitalization or ED visits or even number of physician office visits. And you can see here, there's using recommended medications, can they actually save some cost on the medical services? And again, we can ask the question for Sovaldi as well, right? So this is a super expensive Part D drugs. By taking Sovaldi, can we save some money on the Part A and B side? And also the final one is this came up yesterday a little bit. So if there are some prescription drugs that are covered by Part B, those are the usual injectables that physicians actually give in their offices. In physician offices or a hospital outpatient setting, providers may administer some injectables or the IVs to patient, and those drugs are covered by Part B. Then your question is there any drug that's covered by both Part A and D? Which means that some drugs are available as injectables, intravenous injectables, IV, which is given by providers, but the same drug can be used as a sort of a subcutaneous, which patient can self-administer from home by picking up drugs from a pharmacy. So for those cases, which coverage do patient use? Will they use a Part B drug or will they use a Part D drugs? Right? And that's something that you can answer. And this is probably interesting for the pharmaceutical industry when they do some R&D or develop drugs. They might be thinking, should we develop IV or should we develop oral agent, which would have more consumers, right? So we're going to look at some of these later. So for this segment, I have two sort of parts. In the first part, I'm going to focus on limit the analysis to only fee-for-service sector. So for this one, you're going to use only fee-for-service claims, Part A and B data, and then Part D data. So because this is a fee-for-service claims only, so we're going to take Part D data from only standalone PDPs, and then here we will examine choice between Part B and D drugs, and also we will examine association between Part D drug use and medical care cost. And then we're going to take a break, and then after break we come back, and then I'm going to discuss a study where I used all Medicare data, including Part C data, MA encounter data, and fee-for-service claims, and Part D data, and compare the resource use and both medical and pharmacy resource use, as well as a quality of care. Actually, I looked at quality of care as well between MA and fee-for-service. So research using fee-for-service claims and Part D data. And first, let's look at choice between Part B and Part D drugs. Right. So as I said, Medicare Part B covers prescription drugs administered by providers in outpatient clinical settings, like physician offices or hospital outpatient department. So these are usually IV infusions, intravenous infusions, and Medicare Part D covers pharmacy dispensed home administered drugs, and these are usually oral agent or subcutaneous infusion. So then some drugs, as I said, some drugs can be given by providers or can be self-administered. So both epoetin and prilgrastim. Prilgrastim is chemotherapy supporting drugs that helps prevent infections during chemotherapy process. So these two drugs are available both as a subcutaneous and IV agent. So either Part D or Part B. That's what we are going to look at in this case study. And then another type of this Part B versus Part D drug comparison is that there are some drugs in the same therapeutic class. These are not exactly the same drugs. However, drugs in the same therapeutic class are available either as injectables or an oral agent. So, for example, biologic the rheumatoid arthritis drugs, Remicade, infliximab, is covered by Part B. This is IV agent, but Humira is covered. This is oral agent, and this is Part D. So these are between these two drugs, these are both the RA drugs, effective RA drugs. Which drug the patient would use? That's something that one could look at. But we're going to focus on the first case. So here, so examine the use of a Part B versus a Part D covered drugs. So we focus on epoetin and prilgrastim use among beneficiaries with the cancer. These are both cancer supportive drugs. And here in this analysis, the focus was low income status. And why? So in other words, I compared the use of Part B versus Part D drugs between LIS beneficiaries and non-LIS beneficiaries. Why? Why focus on LIS status? Any thoughts? Anyone who want to share? No? Okay, so in the next slide, I can show here. Now, this is again about cost sharing. So cost sharing in Medicare for Part B, Medicare Part B services is a 20% co-insurance if the beneficiary meets the annual deductible, which is about $200, a little bit more than $200 now. To see if a different version of drugs used by LIS. So let's look at this slide first, so you can have some sense of what I was trying to do here. So this cost sharing is not necessarily small. It could be some burden to consumers. So a lot of non-dual Medicare beneficiaries have a supplemental coverage, which is called Medigap policy. So these Medigap policies, usually they pay for Part B cost sharing. So because of this deductible and co-insurance, beneficiaries buy another policy to cover only this cost sharing portion, right? So then if they are using Part B services, right, their cost sharing will be low because it's covered by Medigap coverage, right? And if you are dually eligible, meaning that you are eligible for both Medicare and Medicaid program, you will cover Part B cost sharing. Oh, so this means that duals or non-duals, probably their Part B cost sharing may be somewhat low because they're all covered either by Medicaid or Medicare policy, right? That's for Part B. What about Part D? So Part D, if you have a low income subsidy, you have a very nominal cost sharing for Part D covered drugs, right? However, if you do not have a low income subsidy, then you have a large cost sharing you could have a large cost sharing for Part D drugs depending on their plan benefits. What is your expectation here? What hypothesis can you develop based on this? If you are, so dual eligible LIS are not exactly the same, but it's pretty much there are substantial overlap. In other words, if you are dual eligible individual, for sure you are LIS. All dual eligibles are almost all dual eligibles are eligible for low income subsidy. However, low income subsidy covers and some non-duals as well. However, these are very much a substantial overlap between this dual status and the LIS status, right? So let's suppose you eligible for low income subsidy. Okay, if you go to Part D, it's very low cost sharing. It's nominal, right? So no deductible, no coverage gap, and just a nominal copayment. Okay, so I could use a Part D, and it's okay to Part B as well because if you are eligible for LIS, you're also likely to be eligible for Medicaid as well. Then okay, even though I use Part B, then Medicaid will cover. So which means that for duals or LIS are more uh, it probably choice between part B and D might not be cost sharing. It might be some preference that whether they want to stay home or whether they have other, that some the Medicare use with any providers, then why not just use part B? However, if you do not have a low income subsidy, when you use part D, you might have a large cost sharing. However, non-LIS, non-duals, if you use a part B drugs, as long as you have Medicare policy, your cost sharing could be substantially low. So now the answers are coming. Thank you for chiming some here. Let's see. Tyler says that LIS is more likely to use a Part D versus non-LIS. Not quite sure, but one thing for sure is that non-LIS is more likely to use a Part B because here, if non-LIS goes to Part D, they might actually face some cost sharing. But LIS, I really don't know. It probably depends on beneficiary preference. So, but anyway, so this is what I wanted to look at. Okay, so here is my study population. So, study sample, I wanted to look at Medicare fee-for-service beneficiaries who had cancer. So we identified the cancer patient. Cancer defined by having at least one patient or skilled nursing facility claim with a cancer diagnosis, or at least two outpatient or hospital outpatient or carrier claims with a cancer diagnosis in a given year. We excluded ESRD patient and we required the beneficiaries to have all coverage, A and B and D coverage for the entire year. And also we require the patient a 12-month enrollment in standalone PDPs. Data sources. Could anyone just chime in here? What data sets do we need in order to study this? Now you know study question, right? This is a part B versus part D drug use. MBSF file for sure, yes, PDE. Is that all we need? MBSF and PDE. Where do you get part B drug use? Outpatient, yes. And do we need only outpatient? Part B data. So what are part B data? Yeah, part A data. Why do we need the part A data? What are part A data? More specifically, carrier, yes. So we need a hospital outpatient file, which often we call the outpatient file, and carrier file. And then that's a B data. What is a part A data? SNP file, yes, you could, but both the SNP and inpatient information, yes, SNP and inpatient information, both are in where? MedPAR. If you actually remind yourself again a little bit, so MedPAR file includes both the discharges from both SNP or inpatient. So you're done. Good, very good. So data sources are here. MedPAR, in order to get information on inpatient and SNP skilled nursing facilities, and outpatient file and carrier file and MBSF file and PDE records. Good, right. So now we're going to construct the analytic file. What is the first step? How would you go about? So you got all these data sets, A and B and D data for fee-for-service beneficiaries. A and B and D data, yes, and MBSF file. And I defined the study sample like this. we're going to go about. Yes, let's identify patient. Yes, filter for eligible patient, right? That's great. Yes, that's our always the first step. So we're going to first apply sample selection criteria. So we're going to use MBSF file first, and then we get some information, age, gender, race, and some enrollment, LIS status, and to exclude the ESRD patient, we get this information and exclude the non-elderly ESRD Part B only, and then we get some demographic characteristics. And that's the first step. So we apply sample selection criteria on the demographic side, right? So the next step is our study sample is what? Cancer patient. I said that I'm going to look at this B and D choice among cancer patient, right? So next step is to identify cancer patient. So in order to identify cancer patient, we actually went through Medicare and outpatient and carrier claims. So to find those who met this criterion, at least the one Medicare claim or two outpatient or carrier claims. So you using the diagnosis code in these three files, Medicare and OP and carrier. Some might ask, hey, CCW chronic condition file for fee-for-service population, they do have cancer indicators, but we didn't use this one because they have only probably 4 or 5 common cancers. Now, the other chronic condition file had a little bit more cancer indicators, but still they do not necessarily capture the all cancer types. So we want to capture all cancer types for our study. So we just use the claims data and then identified those with cancer. What's the next step? What is the next step? So we identify the patient, and then we need to measure outcomes, right? So outcomes are what? Part B, and D use, but we have specific drugs that we are interested in, right? Epoetin and filgrastim. Right. So we need to identify what? Users of epoetin or filgrastim. But users here, we have to separate out those who use Part D drug or those who use Part B drug. Where do we get the Part D, D as in dog, Part D epoetin or filgrastim users? That's in PDE record, right? So we are going to use the PDE records to identify those who used epoetin and filgrastim in Part D. How do we identify? What variable should we use to identify these users? NDCs and HCPCS code. HCPCS code is an NDC code. We are still in Part D space. Yes, product service ID. If you have an NDC code, right? Okay, so I didn't have NDC code. So epoetin and filgrastim, these are still brand name drugs. I think during this period, they both are brand name. Now these actually biologics. So now biosimilars are available. But back then it was all biologics. So we actually used a brand name, because it's pretty simple. There were only 3 epoetin, procreate and arancinib or ipogene or something, and then the 2 filgrastim. So using this, we identify the Part D drug users. Now, how do we identify Part B drug users? Anyone who remember what's covered in HCPCS? That's nice, very nice. And yes, HCPCS code. They are in carrier line items or revenue center data for the OP, and you can use HCPCS. These are usually level 2, and they all begin with a J code, and then that's it, and then you're done. So once you identify this one, now it's just a tabulation, right? So let's look at the results. What do you see here? Wow. So if we can use non-LIS, I'm going to look at non-LIS first. Yes, 90% of non-LIS beneficiaries use Part B, which makes sense, right? So these beneficiaries are likely to have a Medicare policy. So for Part B drug use, they didn't have much cost sharing. But if you Part D, about 10% use of Part D, they might have a little bit more generous Part D plan benefits. What about LIS? It's pretty split, right? 53 versus 44%. And this one, I don't know. I don't think that this is a cost sharing effect. That this is a more preference effect. Which one is more convenient to this, or which one they like, right? What about Pilgrim's non-LIS? It's very similar. 93% of non-LIS use a Part B, about 5% use a Part D. LIS, it's a little bit more actually geared towards a Part B. A little bit surprising if prices are the same. Some might actually prefer some more Part D. However, I think this is because this is a filgrastim is used is a chemotherapy supportive drugs. So if they were using Part B cancer drugs. A lot of cancer drugs are currently IV injectables. Then when they go in to get the chemotherapy, they might actually have gotten filgrastim along with the chemotherapy. That makes sense. Then they don't have to visit again, or they don't have to self-administer subcutaneously from home. And that's what might actually explain this. Right. So any questions? And this, I'm going to move to the another topic. So far, this is a Part B versus a Part D drug use. If not, I'm going to move to now actually looking at is the result per patient or per record, and this is a per entire group. This is analysis. Unit of analysis was a patient, so we followed each patient whether they use a Part B or Part D. But this patient was aggregated up to the entire sample. It was a patient, not per record. Now, the next topic is association of a Part D drug use with medical care cost. So since I was looking at Sovaldi, I was really interested in what does this Sovaldi or this new Hep C drugs do in terms of both cost and mortality. So I'm going to introduce the study on cost, follow-up cost. So this is actually official therapeutic class name for Sovaldi. So that's called the direct acting antivirals, DAAs. And DAAs include Sovaldi and Harvoni and Bicara. And there are more newer drugs as well. So these drugs are used to treat the hepatitis C virus, and they have a really high cure rates, more than 90% are cured once you take these ATAAs. Administration is easy, one pill per day, and it's only 12 weeks of treatment. Sometimes it's only 8 weeks. Now, however, DAAs are very expensive, and then some cost effectiveness studies really justified high cost of these drugs, because even though it appears that what their argument was that even though it appears to be expensive at $84,000, however, you might actually save more down the road. Downstream, you can save more downstream medical cost. But this is just based on simulation. The way they calculate the medical cost is once you cure means that in your blood, in your body, there is a very minimum viral load. So if you don't have a viral load in your body, you don't develop complications. So they actually really simulate it. So how much they can save in medical costs in cost effectiveness studies. So I want you to look at the real world evidence. Is it really the Medicare saves money after using DAAs? So this objective of this study is that to examine the relation between DAA use and follow-up medical cost among Hep C patients in Medicare fee-for-service. So study population is Medicare fee-for-service beneficiaries with Hep C in 2014. So we identified those beneficiaries who were who had the first Hep C claim in 2014 after 1 year washout period, which means that they should not have any Hep C claim in 2013. So we don't know the prior to 2013, but at least 2014, they didn't seek any health care because of a Hep C. So this is 2014 Hep C patient. And in order to identify Hep C patient, we followed again CCW algorithm. It's very similar, having one inpatient or skilled nursing facility claim with a Hep C diagnosis, or at least two outpatient and carrier claims with Hep C diagnosis. And then again, required beneficiaries to have the full Medicare coverage, or A and B and D. Now, our outcomes, I measured the two outcomes. The first one is the total medical cost, and the second one is Hep C and liver-related medical cost. So medical cost included spending on hospital facility, inpatient data, skilled nursing facility, inpatient SNP data, right, and then outpatient facility and professional services. Data sources. So we actually used, we followed up. So 2014, our study sample comes from 2014 Hep C patient, right? But we followed this patient up to 2017. So what are data sources here? PDE, for sure. So we want to get the DAA users, right, from PDE. I think you need almost all the files to find the total spend. Yes, that's true, right? That is true. I did not actually include the home health or hospice or DME, right? So it's very much inpatient and SNF and hospital outpatient facility and professional services that comes from the carrier file. So yes, it is correct. So we had MBSF for sure to get demographics, and carrier outpatient, and Medicare includes both inpatient hospital and SNF. We did not have a DME or a home health or hospice, right? It's just simply our definition of a total medical cost. And then we had this PDE records for sure. How do we construct the analytic files? What's the first step? Same, right? So we want to apply a sample selection criterion, right? First, we use the MBSF file, and then we applied some coverage restrictions, or again, probably excluding ESID as well here. I don't see any comment here. But just some coverage requirement, and then we also get some demographic and the health risk variables from MBSF file. We use the condition, the CCW condition indicators, chronic condition indicators, and probably simply use these indicators in the regression model. Yes, in order to exclude, yes, using MBSF file, of course, we can exclude MA in your list, right? This study is about only for people service. So once you apply this selection criteria based on demographics or some other coverage conditions, the next step is identifying our sample who are Hep C patient, right? So here to identify Hep C patient, this is where we use the 2013 data. 2013 data were used only to check this 1 year washout period. So we used diagnosis from 2014 Medicare and OP carrier file and make sure that they didn't have any Hep C diagnosis in 2013 data, and apply this CCW criterion. And then we defined this one as we didn't say this is a newly diagnosed, this is sort of who are newly seeking Hep C related care after 1 year washout period. And so we identified our sample. The next step is what? We are looking at, again, what is the study aim? We are looking at the relationship between DAA, the new Hep C drug use, and medical cost. So the next step is identifying, yes, drug users, correct. Just quickly, the one question in the Medicare claim is inpatient claim. Medicare include both inpatient and skilled nursing facility. Right. So construction. So we identify DAA users, and how? Using PDE records, right? So again, how do we identify each drug? So we use the PDE records. You could use a product service ID. These are very small set of drugs. DAAs were really new. And there weren't many, only a couple of dozen of drugs maximum. So in any way, you could actually identify using website, identify all the drugs available, including NDCs. So you could use NDC or B and the brand name or generic name. And I think we use the generic name in these drugs. sofosbuvir is Sovaldi, and this is probably Havroni. So once we identified this DAA users, now what's the next step? So we have these DAA users, and then we want to see their what medical cost, right? But from when? So when you construct any cost variable, you have to really define, the period that you are looking at, right? But remember, this is a follow-up cost. So what we need to do is we need to have some starting point, which we usually call the index date, right? So from that index date and how much, right? Medical cost, right? Yes, time zero, initiation of a DAA. And that's what I wanted to say here. When you use a PDE records, once you select all these drug users and this, you have to identify index date, right? So using our PDE records, we define the index date as the date of the first DAA field using service date, right? This variable. And also we calculate the DAA cost, but I don't think we used this one. So the key here is that identifying index date. And then we identify the index date, and you have to carry this information from part D to part A and B data, right? Because we're going to calculate medical cost only from that index date, right? Before that, we are not interested in, right? So we use MedPart and OP and carrier files, part A and B data, and then you use information instead of a link. Use information from part D, DAA, use an index date, and then apply this information to these A and B claims, and then calculate the medical cost based on the Medicare allowed payment in these three files, and every 6 months, starting from the index date. So and then we follow them up to 2017. And one thing that we did is that we identified the presence of cirrhosis using A and B data in the index year, because cirrhosis is it's somewhat serious, and this is a little bit more shows the disease progression, Hep C progression. So I expected that the cost will be very different between those who already developed the cirrhosis because of a Hep C virus and those who have not developed cirrhosis yet, right? So this is okay. So so far we've been focusing on only treatment, right? So I wanted to have a control group as well. So treatment group that's our study sample, right? And I said, okay, so these are, we are looking at follow-up cost after the DAA use. So our treatment group is a patient who used the DAA treatment, and index date is the first date of DAA use. But I want you to have a control group. In other words, you have a Hep C patient. We identify the Hep C patient in the same way. However, they didn't use the DAAs, so they remained untreated. So they really save more money by using more expensive drugs. Now, the problem of having this one issue that you have to address is, for this control group, what is index date? They didn't initiate the DAAs, right? So so you have to come up with some index date because we have to follow up in the same way. Yes, setting time zero among non-users is hard. So the way, let's see, I'm going to explain here. Idea is that we're going to actually, so we got the time from diagnosis to first prescription date from treatment group. So for everyone in the treatment group, those who use, their diagnosis date is somewhere in 2014. And then we can identify when they start using DAAs. So there is a time to treatment from diagnosis. So we get that distribution from treatment group, and then we applied that distribution to control group. So both the treatment group and control groups will have the same prescription time distribution after we assign fake index date to control group. So it might be easier to look at this diagram. So everyone, whether you are in treatment group, DAA use or non-use, you both are diagnosed in 2014. So when I looked at one DAA users, they initiated DAA here. It could be 2015 or could be 2016 or at the end of 2014. So there's some pre-treatment period. This is a time to treatment, right, from the diagnosis. So for these patients, we have to have one control group who has the same time to treatment. Then we can assign this fake index date to that DAA non-users. Right? And we assign this fake index state to DAA users such that this distribution of this time to treatment is equal between DAA users and non-users. So each the non-users have some fake index date, and then we pretend that they have some treatment, and there is some treatment period, and then we begin to follow up this every 6 months. And for each every 6 months, then we're going to calculate medical cost. Right? Okay, so this paper is published in a journal, and I think I shared the article that we published this one. The result that I'm showing today is slightly different. These are coming from a pilot analysis. The idea is almost the same. The conclusion might be probably similar, but not the numbers are not exactly the same as in the published papers. So here are the results. These are unadjusted. So unadjusted Hep C related spending. And you can see here, let's first look at the cirrhosis, those with the cirrhosis. But first of all, you can look at how, difference in total cost between those with cirrhosis and non-cirrhosis. This is only Hep C and liver related spending. Those who already developed the cirrhosis, they actually spend a lot on medical care, right? So anyway, so these blue bars are users, DAA users, and orange bars are non-users. And what do you see? Pre-treatment. This is from the diagnosis to until they initiate the DAAs, right? Users are slightly higher, and this is because you need to do a lot of testing to get the DAAs. So that's why probably these users have did more testing to ensure that before they take DAAs. But after that, once they complete their treatment, you can see the follow-up period. Oh, really? The users actually did save some money, right, over time, and actually lasted until here among cirrhosis. When you look at those who didn't develop cirrhosis, yes, the users have more spending during pre-treatment period, but during the follow-up period, it's not necessarily, still users actually have more spending. And probably they are doing more checkups. And then over time, there is no difference in medical spending between users and non-users if they didn't have a cirrhosis. Right? And this is a Hep C and liver related spending. And this is a total spending, regardless of whether they was treated for Hep C or not. And you see a similar pattern, those who have a cirrhosis, those who use the DAAs, they save a lot. And now that pattern happens even for those without cirrhosis as well. So in summary, we found some reduction in Hep C liver-related spending among DAA users, and that reduction lasted during 3.5-year follow-up if they had cirrhosis. And reduction in total spending lasted only about 2 years after treatment in all patients, meaning that regardless of they have cirrhosis or not, in both people with and without cirrhosis, right? So that's the summary. Any questions? Oh, how do you define Hep C related spending? For each medical claim, we looked up to whether there is a Hep C or liver related diagnosis. So we just selected only those claims that has a liver or Hep C diagnosis. I think in the paper we provide the code that how we defined in the supplement somewhere, how we define the Hep C and liver-related diagnosis. ICD either 9 or 10 because it's a 2013 through 2017.